So we have a few attendees here, but I think we have several more people registered who will join us, but we'll go ahead and get started. My name is Quinn Conklin, and I am currently the Executive Director of the Stress Measurement Network, one of the two networks who is co-hosting this HRS webinar, so the other being the Emotional Wellbeing Network. And we will be hearing from 3 Blitz speakers today about some of the data from the HRS set of studies, and then we'll also be hearing from Dristin, who will give a little tutorial about how to get hands-on with this data and use this data. But before we get started, I will mention that we'll be using the chat feature to take questions, and we will hopefully have time for 1 to 2 questions after each speaker. So please feel free to put your questions in there. Yeah, I think that's all to get started. Alyssa?
Thank you, Quinn. I'm Quinn Conklin is the Executive Director of the Stress Network, for which one of the aims of the network is to help people become aware of and utilize harmonized data from over 10 countrywide population-based studies of aging. And we have been working on harmonizing both stress-related data and emotional well-being related data with the amazing work of Jackie Smith at Michigan and Dristin and Jen Cook's team at USC. So my name's Alyssa Eppel. I'm one of the directors of the NIA Stress Network. And we are so delighted that you decided to spend the hour with us, because we think that being able to access this data and ask important questions about population-based aging and malleable factors like stress and well-being is an amazing gift to researchers. And there's a little bit of an investment to get in and to learn how to access the different countries' databases and to use the harmonized variables. And that's what we are so happy to help you with today by giving you some time with Dristin Phillips. And so that is, there's just so many amazing questions and unused data. So we hope that you will spread the word. But in the meantime, we've brought you 3 young scholars who have spent the time getting into these databases, asking great questions, and really finding out some new knowledge and some mechanistic information about levers of psychosocial aging, I will say. And so we get to hear them first, and we've made it a data blitz, so it's going to be quick. Hold on, 5 minutes each, and time for 1 or 2 questions. So we'll start with Yubin Park of UCSF. Welcome, Yubin.
Thank you, Alyssa. I will. Can you see the screen? Hi, everyone. My name is Yubin Park. I'm a postdoc researcher at UC San Francisco. And I'm gonna be presenting our work on life satisfaction and its relation to blood pressure today. So there's now much evidence suggesting that people who are higher in emotional well-being tend to have better physical health outcomes. However, the link between emotional well-being and cardiovascular health remains less clear. For example, some studies find that people higher in life satisfaction are less likely to have blood pressure problems or hypertension, but other studies find no such relationship. The goal of this research was to conduct a rigorous investigation into this association by drawing on multiple data sets across the world. So we searched for data sets from studies that assessed life satisfaction and also had trained interviewers or nurses measure participants' resting blood pressure. We located 16 such data sets, and some of these data sets were from longitudinal studies, and for those, we used the earliest wave at which both life satisfaction and blood pressure information were available. And you can also see that 4 of the data sets here were from the HRS families of studies. And here is a map illustrating the countries where each study was conducted. In In total, we had more than 100,000 participants, slightly more female than male, who are on average around 60 years old. For the analysis, we classified the participants as hypertensive if they had resting blood pressure that meet the criteria for hypertension diagnosis, or if they were currently taking antihypertensive medication. In each data set, we fitted up a Poisson regression model with a log-link function and robust standard errors to examine how life satisfaction is associated with hypertension status. Then we conducted a meta-analysis using the effect sizes from each data set to look at the average association. So what did we find? So as you can see here, the average risk ratio is not different from 1, suggesting that life satisfaction was not a significant predictor of hypertension status. We also tested several study-level moderators, such as whether single-item or multi-item scale was used to assess life satisfaction, but we didn't find any significant effects here. In fact, as you can see in this figure, except for one data set, there was no evidence that more satisfied people are less likely to have blood pressure problems, which contradicts some of the previous findings. So what we then went forward to do was to look at the link between life satisfaction and blood pressure the way previous work did. So in previous studies that did find a significant association, researchers relied exclusively on self-reports to infer hypertension. They coded participants as hypertensive if they reported having been diagnosed with hypertension and/or if they were currently taking antihypertensive medication. So first, we asked how similar or different the self-reported measure is from our way of coding the hypertension status, which partly relied on the measured blood pressure. And we found that across data sets, more than half the participants whose resting blood pressure levels did meet the criteria for hypertension would report no doctor diagnosis or hypertension medication use, suggesting that they'll actually be coded as not being hypertensive. So how does this affect our primary results? So we reran all the models again, now using self-reported hypertension status as an outcome. And now we found a significant meta-analytic link suggesting that people higher in life satisfaction have a lower risk of being hypertensive. To summarize, our analysis of 16 data sets did not reveal evidence for a significant link between life satisfaction and hypertension status. But interestingly, when we relied exclusively on self-reports to code hypertension conditions, we did find some different results. And this difference highlights the potential limitations of self-reported health data, and it also helps us understand the inconsistencies in the literature regarding the relationship between life satisfaction and hypertension. Thank you so much for listening, and these are my awesome collaborators and funding source. Thank you.
Thank you so much, Yubin. I know that was a tremendous amount of work, and it's still important information, even when there aren't relationships there. That's a tremendous contribution. We have time for a few questions. So you can chat your questions into the chat.
I will say, I think we need folks to use the Q&A feature. I think chat is only open to the panelists.
Okay. Okay, we will move on. Don't be afraid to ask questions. If you have a question, others do too. We're going to move on to getting to hear from Abby Hillman of University of Pittsburgh. And Abby will be talking about inflammation and different aspects of stress across the lifespan. And I will say this is one of the most integrative and thorough analyses of life events that I have seen. It's kind of been our dream to see people use the data in this way so that we can understand impact of stress at different periods of lifespan. Welcome, Abby.
Thank you so much, Alyssa. I hope I can cram it all in 5 minutes. I'm excited to share my project with you all today. Let's see. Does that look good to you all? Okay, excellent. So I'm Abby, and like Alyssa said, I'm going to be telling you about the associations between life stress and inflammation. And we conducted this analysis in HRS and ELSA cohorts. So previous research has identified that stressful life events can have a cumulative effect on physiological health, and in some cases lead to higher levels of inflammation. But what is less well studied is whether or not there are critical developmental stages that might confer greater risk for physiological outcomes. And in this area, most research has really focused on childhood, but very few studies have actually compared the effects of stressful events that take place in one life stage to those that take place in other life stages within the same statistical models. So we set out to test both of these different lifespan models, looking at the cumulative effects as well as the effects of the numbers of stressful events that take place during unique life stages on levels of inflammation. And to do so, we integrated HRS and ELSA cohorts for a total sample of almost 8,000 individuals with an average age of about 69. And we had slightly more women than men.
Sorry, Abby, I'm going to interrupt you because it seems like people can't see your slides.
Oh, no.
Can other folks let us know if that's happening for you too? I was able to see them.
Oh, interesting. So the panelists can see them, but not
Right.
the participants. Okay. Let me try doing it just by sharing like a portion of screen and see if this works out any better.
All right. Amanda and our anonymous attendee, can you, either of you, confirm whether you can see those now? Now it looks better. Okay, thank you. Sorry.
Excellent. That's okay. We haven't made it to figures yet, so now's the time. So like I said, we have about 8,000 people, and this is a sample of older adults. And across the two cohorts, we have 7 different items that we could harmonize, and that included whether they had ever lost a child, had any combat experience, etc. And the most commonly reported event was illness of a close other, followed by illness self, natural disaster, and partner addiction. And for every stressful event that was endorsed, the participants told us roughly what age they were when it took place. And given the ages that the events took place, we categorized them into 4 different distinct life stages that were developmentally informed. And so this figure that I'm showing here demonstrates the variation in different event types that took place within the 4 life stage ranges that we created. And you can see there was substantial variability. Our outcome variable was C-reactive protein, and to harmonize, we excluded outliers, log transformed, and then used the proportion of maximum possible scores technique to account for any methodological differences across the 2 studies. Our primary covariates were age, sex, BMI, smoking status, and the time that elapsed between the survey completion and the blood draw, where CRP was measured, and then the cohort status. And secondary covariates included race and education. So for primary analyses, we did the cumulative effects first, followed by lifespan main effects models. And then lastly, we did independent effects models where we put all of the life stages into the same model together. And for each stage of model building, I'm going to show you 4 different sets of sensitivity analyses where we covariate for race and education, which could be important because socioeconomic status especially could compound the effects of some of these stressors. We dropped the health-related stressor from our event count to ensure that that wasn't directly increasing inflammation. We dropped people with CRP above 10 to ensure acute illness was not a confound. And then lastly, we added in some childhood-specific stressors that included parental abuse and parental alcohol abuse to make sure there was an equal chance of events happening in all life stages. So this looks like a lot, but we're going to fill this out 1 row at a time, starting with the cumulative effects. And what you can see here is that experiencing a greater number of events was associated with higher levels of CRP. And across all of our sensitivity analyses in each of the columns, you can see this was largely robust. And next, getting into main effects models, I'm going to show you all of the independent life stages. And you can see that only young adulthood emerged as a significant predictor of higher levels of CRP. But this finding was also robust to all of our sensitivity analyses. And then now independent effects models, and you'll note here this is a smaller sample size because participants had to be 65 and up to be included to ensure that they all had a chance of having late adulthood events. And what we found was an association between midlife and higher levels of CRP. And the young adulthood association that previously was in main effects is slightly attenuated, but still approaching significance. And what I want you to notice here is if you look at the trends, it does kind of come in and out depending on the sensitivity analyses. So in conclusion, this association between cumulative total and stressors in young adulthood and midlife were consistent in a sample of almost 8,000 individuals and robust to all of our sensitivity analyses. So the real question is why young adulthood and midlife? And it could be that individuals in these life stages not only are experiencing these events, but they hold the most responsibility as support providers for their family members, both young and older than they are. And lastly, thank you to my collaborators on this project.
Wow, thank you so much, Abby. And again, we have time for Q&A in the Q&A box. In the meantime, while you're typing in a question for Abby, we had a question for Yubin. Yubin, do you want to answer live? Repeat the question too.
Yeah, I was actually just asking in the chat if I'm the only one who can see the questions. So the attendees can't see these at all.
The attendees can see the Q&A. So one question, which is life satisfaction mean the same thing across cultures and countries, which is a fundamental question for all of these cross-country comparisons.
Yeah, so that's a great question. As I said in the chat, I think it's possible that life satisfaction, well, there is also work suggesting that life satisfaction is differently affected by different life domains across cultures. So I think it's possible that life satisfaction is representing somewhat different construct across cultures. We weren't able to test directly if that is the case in all the studies I used here, or as far as I know, in the HRS families of studies either. But yeah, I think it'd be great to look at how that might affect our results. If there's certain part of life, if certain aspect of life satisfaction that can be more strongly related to blood pressure levels or hypertension status.
Great. Thank you. And we do have a question for Abby. First of all, great analysis. Were there other inflammatory markers that you could look at across cohorts?
Yes, so we actually, there weren't any other that we could harmonize, but we did look at additional biomarkers within the HRS sample, including IL-6 and TNF-alpha, and the trends were largely consistent.
Mm-hmm. And it brings up the great point that there are, a richer sets of biomarkers within country data sets. And then when you look across country, of course, we're often more limited. Okay, wonderful. So we're going to move on to our second to last speaker. If you have questions, still you could enter them in the Q&A and our speakers can chat in the answers. So I'm so pleased to bring you Jae-Young Park, who is an associate professor at the Korea Advanced Institute of Science and Technology. And she comes to us live from Korea at 4 a.m. You're so generous to get up so early for us. Thank you. And she was also a amazing postdoc at UCSF. Welcome.
Okay. Hi, everyone. It's very nice to meet you early this morning in my time. Please bear with me. I'm not entirely clear. I'm a leader's for a. Right. So I'm very excited to share a recent analysis based on this amazing data set. We all know that social relationships are integral, right, to our health and well-being. It's very important. And considering the salubrious effects of social connection, it would not come as any surprise that lacking social connection is detrimental to health. So numerous studies found that perceived social isolation is a serious health risk. And in fact, such a perception can be fatal. And according to a recent meta-analysis, loneliness predicts 22% increase risk of mortality. But the critical limitation of this literature, especially this current evidence, is that it is almost exclusively based on populations from North America and Western Europe, the cultural groups often referred to as weird. So for in the previous analysis, meta-analysis, only 3% was based on non-weird populations. So therefore, there is an urgent need to reassess the mortality risk of loneliness based on more culturally inclusive research that goes beyond the boundary of weird societies. And here we aim to fill this gap by examining the mortality risk of loneliness in 4 countries, including two Western and then 2 non-Western countries. And we hypothesize that individuals from collectivistic cultures such as Korea and Mexico would be more vulnerable to the mortality risk of loneliness compared to those individualistic cultures such as the United States and England. So in addition to one's personal dissatisfaction with the achieved level of social connection, loneliness may create another layer of burden in collectivist cultures by highlighting their failure to achieve their cultural mandate to establish social connection and maintain social harmony. And when it becomes excessive, this experience of cultural misfit can entail negative health consequences to the point that it may ultimately lead to premature death. So we tested this prediction by comparing the 10-year mortality risk of loneliness from these 4 countries using the harmonized data set based on ELSA, MAHS, NHRS, and CLOSA. And for all countries, we tested whether baseline loneliness, which was assessed in 2002 in England and Mexico, and in 2006 for the US and Korea, how they might predict loneliness, how they might predict mortality 10 years later. And then we conducted a 3-step hazard model that variates, including each step, such that we control for demographic variables in step 1, and we additionally control for health behaviors and health conditions in steps 2 and 3, respectively. And first of all, so we found that the four varied in their loneliness. As we can see from this figure, the loneliness level tended to be higher in the collectivistic countries than in the individualistic countries. And then we conducted the main analysis. And after adjustment of demographic variables in step 1, loneliness significantly predicted increased mortality in all 4 countries, with 16% increase in England, and 30% in the United States, and 21% in Mexico. And finally, in Korea, it was 53%. So what is really noticed over here is that the HR ratio of Korea is even greater than 2/4 of the risk that are shown in the other countries. And as implied by this pattern, the culture by loneliness interaction was highly significant. And the results were similar when we additionally control for health behaviors. And finally, when we control for health conditions, the hazard ratio was no longer significant in England, United States, and Mexico, but it remained highly significant in Korea. So as you may expect from this pattern of cultural difference, the interaction effect was driven by the contrast between the Korea and the rest 3 countries. So altogether, our analysis shows that the mortality risk of loneliness is culture bound. So when people feel that they are chronically isolated from social network, this perception can be fatal in Korea, but it is less so in the other 3 countries. Then how can we make sense of this result? So we theorize that the mortality risk of loneliness would be higher in collectivistic rather than individualist countries. And our Korean data proved consistent with this prediction. But curiously, the mortality risk of loneliness in Mexico and other collectivistic culture was substantially lower. And in fact, it was no different from the risk in the United States and England. And clearly more work is needed to understand why Mexico and Korea differ in their mortality risk, despite their cultures' shared emphasis on collectivism. So taken together, our data underscore the need for more culturally inclusive research that to globalize the theories on the health impact of social integration. Okay, and thank you everyone. And maybe we have time for maybe some questions.
Yes, we have time. Wonderful analysis and fascinating results. So, Ji-Young, there are several questions in the Q&A. One question is, what type of close relationships, parent, romantic, friends, do you think might be the most critical to one's health in East Asia?
So which type of close relationship do you think might be the most critical for one's health in East Asia and why? So I don't know. I think that's an interesting question. Yeah, I'm not sure whether, I don't know, my gut feeling is that I don't think I don't expect to see much of variation in terms of the source of, right, the social connection. So maybe overall the social connection might matter more in collectivistic cultures. Yeah, but it's an interesting question. I haven't really thought about whether different types of relationships matter for a certain culture compared to other, but yeah.
And maybe Dr. Wang, who answered the question, wants to type in their thoughts. You know, often there's a data or hypothesis behind a question. Another question was about gender differences, particularly in Mexico. Have you looked at gender interactions or?
Oh yeah, we tested some sample characteristics and how they moderated. Curiously, there was no gender effect, so no moderation by gender, but there are some other sample characteristics that turn out to be a significant moderator, but gender was not one of them. Yeah.
Oh, thank you so much. Okay, well, we have a few minutes before we're going to turn to Dristan, which is always rare and surprising for Q&A, the funnest part. So we are inviting questions to any of our speakers, including questions to each other. And I think it's, you know, this set of studies is so impressive because of how many countries you have compared to each other, and because of these theoretically motivated questions that you've had about well-being, about loneliness, about stress and lifespan. So it's just such a great example of how this data can be used for really fundamental questions about stress and aging and well-being. Alex is going to ask a question live. Welcome, Alex.
Hi, thank you for having me. I wasn't trying to put this in writing, so Abby, my question's for Abby. I hope you'll forgive me if this comes off a little bit scattered. So I come out of a stress process perspective, and really where that really got founded was Len Perlin's work in the early 80s. So this is going back a while. And what he basically said was in this paper that published in JHSB in 81 was that if we look at the relationship between negative life events, and at that point he was just looking at mental health, like depression, he basically said, well, this whole thing's process, this whole association. So if we just look at negative life events to an outcome, in a lot of cases, this association may be underestimated, because we have to think about processes of stress proliferation and how then these indirect processes are all contextualized and with other personal resources and larger structural contingencies. So with that in mind, especially given that you seem to find that there seems to be a sensitivity period, have you considered about how these data could maybe be more leveraged to look at these different contextual contingencies, especially in terms of indirect effects through stress proliferation? Because it may be that you find that some of these cumulative effects of negative life events are only seen when you take these contextualization and indirect effects into account.
Yes, I think that's a huge question, how to take into account contextual effects. Can you give me like an example of exactly kind of what you're thinking of? Like, is it like?
Oh, I'm not exactly. This is the thing. I said it's kind of scattered in this, but I'll give you kind of the classic example of Perlin and colleagues, where job loss leads to financial strain, leads to mental health, but the extent to which all this happens depends on whether or not people have a strong sense of control, i.e. history. So, you know, I'm just kind of wondering here if you could put in, for example, even something as simple as some sort of indirect effects, and then like, something like, does social support or something contextualize the extent to which these indirect effects of stress proliferation happen?
Yeah, absolutely. I've been thinking about that a lot myself. I'm really interested in social support and buffering. One of the limitations is because this is retrospective, like we don't really know what the context was necessarily when the event happened, but that's on my to-do list. I'd like to try to pull together some data that's maybe prospective, where we could look at concurrent associations and moderators.
Excellent. Thank you. I really appreciate it.
Yeah.
Thank you, Alex. Great question. I love it when the pioneers of stress research are, and their proteges are brought up, because I think there's so many really fundamental lessons about stress and understanding stress processes that we want to remember and not recreate the wheel. Jae-young, did you want to mention anything before we move on about any moderators that you found in your analysis of loneliness?
Oh yeah, so we found the education moderated, but surprisingly, it was those with higher education who actually were more vulnerable to the mortality risk of loneliness. And it turned out, a lot of Mexican sample was in general was less educated compared to the Korean sample. And then given this additional analysis, we suspected that maybe the sample characteristics may have contributed to the dissociation between the two, because Mexicans were lower in education, and somehow they were less vulnerable to the mortality risk. But there was an anonymous attendee who made a really interesting comment. So there have been distinctions made regarding the qualities of collectivism between East Asian and Latin American countries. So I'm aware of this recent literature. And then there are different facets or different types of collectivism. So in Latin American culture, so there is a greater emphasis on expressiveness of especially positive emotions, in terms of emotion sharing, and expression of these positive emotions is a really important means to reach and connect with, maintain social connection with other people. And then it is completely possible that maybe this form of collectivism may have provided some protection against the mortality risk of loneliness in Latin American cultures. Yeah. I think that's a really great perspective. Yeah.
Wonderful. And it just brings up a point, question for all of you listening, which is that it's such a amazing opportunity to compare data cross-culturally. And then we're left with wondering, is the construct mean the same thing? How can we measure culture in these countries? And so that is a set of, in a sense, missing variables that everyone would love to help us understand culture, health, and aging. And our stress network is going to be working in its next period on really understanding what measures we should be adding of culture. We'll be working with cultural experts. Jae-young will come to you too. And this is a chance to type in to the chat or even the Q&A any measures. What's on your wish list for the health and retirement family of studies, the around the world studies? What do you wish that you could add to their battery? There are a lot of studies starting up in different countries, and there's also PIs that are open to adding measures. And as part of the Stress Network, we're in dialogue with suggesting high priority measures. So as you think about that, I would love to turn this over to Dristin. Anna Noreg asked the question of how do we access these databases? And so this next almost half hour is precious. It's recorded. And Dristin is really the deep expert on accessing the data, harmonization, what to do when you get stuck, et cetera. And we're so grateful for all your work. Thank you, Dristin.
Yeah, thank you. I'm happy to be part of this. And those 3 presentations were great. It's really encouraging to see like such good research coming out of this network of studies. So I'm going to talk a little bit about the Gateway to Global Aging data, kind of as a resource for anyone looking to use these kind of stress and emotional well-being variables that are collected. Briefly, the Gateway is a free public resource designed to facilitate cross-national and longitudinal studies on aging, and it's funded through the National Institute of Aging. And it really focuses on what we typically call the Health and Retirement Study International Network of Studies, or HRS-INS. And you can see here the 17 different studies that kind of we focus on. There are some additional ones that aren't mentioned on here. For instance, there's a Canadian longitudinal study. We focus particularly on these because they have ongoing data collection. The data is free and publicly available for researchers around the world. And they've kind of asked a general broad set of questions that are comparable to each other. So there are some additional ones in addition to these, but we focus more on these. And I just want to highlight, so lots of these studies do include stress measures. The columns in this table stand for the different studies. And then we have some different domains of stress, and you can see where the different domains were included. I think one of the things that jumps out is, of course, like not all stress domains are asked in all studies. I think we would love to see broader inclusion. So, I echo Alyssa's call that if there's measures that you think are really important, that we try to encourage these studies and new studies that are coming online to include those. But you can see that some degree of stressful life events and traumas is asked in every single study. Similarly, loneliness is very commonly asked about. But, for instance, experiences of discrimination are only asked in 3 of these studies that are highlighted here. Neighborhood disorder or kind of environmental cohesion are only asked in 4. So some of them don't have quite as much coverage. And switching to emotional well-being measures by study, you can see that particularly the HRS United States, ELSA in England ask a lot of these emotional well-being questions. In some studies, it's a lot fewer. The most popular ones are the kind of the single item life satisfaction or domain-specific life satisfaction. But CASP questions are asked, in many studies. And particularly, I'll highlight the study here called SHARE, which is a European-based study, but it in itself includes more than 20 different countries. So there's a lot of comparability just from these. So the gateway is kind of designed, to help researchers who want to get access exactly to that question. So I'm going to highlight some parts of the gateway that really help you kind of get started and get access to the data and think about what's the harmonized data that's been created for this. So we've built as part of our project what we call harmonized data sets, where we've already created kind of comparable variables between these different studies. So the first thing I'll highlight on the gateway, which is just that we have study overview. So you saw lots of these studies being talked about, but it's really important also to think through like, what's the study design? Who is it asked to? And there are some differences. I've put up here just the example of how ELSA, that's the English Longitudinal Study of Aging, is asked. So it's asked to everyone who is 50 or older, plus their spouse of any age. It's nationally representative sample. They follow people into institutions. Whether people are followed in institutions, particularly is like an important kind of sampling design to think about, especially if you're thinking about older ages where there's lots of institutional care. And currently it doesn't include any oversampling, but I believe in this next round they plan to oversample ethnic minorities so that you can get a better sense of the ethnic minority aging experience in England. We also highlight when their data was collected. The HRS United States started in 1992, but many of them started later. Many are, being planned their first wave now, actually. So you can see that wave 1 of ELSA was in 2002, and lots of different types of data are collected, including core, end of life, life history, self-completion, health assessment, blood-based biomarkers. They've done a kind of in-depth cognitive assessment we refer to as an HCAP. They've collected genetic data. They have COVID-19 interviews. So, I think particularly interesting is thinking about linking these stress and emotional well-being measures that we're going to talk about to different things that we know about. One of the powers of these studies is that they're multidisciplinary. They're not just well-being or psychological studies. They're not just labor force or economic studies. They really try to capture like the multidimensional aspects that affect people's aging and aging experiences. It will give you also an idea of their samples, whether they have resampled, and linkages to administrative data. For instance, ELSA includes linkages for mortality, healthcare utilization, cancer records, pension, and pensions. How to get access to the study data, and we highlight harmonized data sets that have been created. So in this case, in the case of ELSA, there's 4 different harmonized data sets. That first one there is for the core, that's kind of the repeated assessments. We also have one for end-of-life data, life history data, and the HCAP cognitive assessment data. And for the rest of this presentation, I'm really going to focus on the core data because that's where most of these stress and emotional well-being measures are. On the gateway, you can find all the survey questions. You can see here that they start at different waves. You can search through the questionnaire. So if there's a question you're wondering, is this available in a specific study? For instance, here I just looked for the keyword depress and limit it to ELSA. And we can see lots of questions here in ELSA about depression. And we've also built a question concordance, so you can see the availability and comparability of survey measures across time. And so you can see here, I've selected kind of 2 questions around loneliness. I believe these are both from the UCLA loneliness scale. So how often do you feel a lack of companionship, and how often do you feel left out? And so you can see that these are asked in HRS, MHAS, which is the Mexican study, and ELSA, the English study. But you can also see that there are some differences in the response scale. So at waves 1 through 3, there was a response scale difference for ELSA, and at wave 6 of HRS. And so I think especially when you're planning your question, it's really important to think about what are the measures that I can use, and especially in a cross-study, cross-national comparison, making sure that they're comparable from the set in your planning stage. This is really helpful for that. We've also developed domain-specific user guides. I've highlighted here 2 of them, which are particularly apt for this presentation, which is one on stress and one on emotional well-being. And so these 2 guides really go through what are all the stress measures and what are all the emotional well-being, or some of the, when in this case, we refer to this emotional well-being measures here in these guides. And so these are long guides, and you can see what questions are asked. So talking about these harmonized data sets, so these are created to provide comparable research-ready variables. That means we define variables as similarly as possible across all waves of each study, so they're longitudinal, and across different studies, so that they're used for cross-study analysis also. Each data set combines all the waves from each study, and each individual is one record, so they're called FAT files. And all variables use kind of intuitive variable names, and study-specific variable names are used to indicate a significant interstudy difference. Currently, the Gateway produces 5 different types of harmonized data: core, end-of-life, life history, HCAP, and COVID. I'm just going to focus on core mainly because I think that's more applicable. But also, if you wanted to bring in, for instance, some life history measures, maybe people's experience during COVID, people's experience at the end of their life as related to these stress and emotional well-being measures during their life, I think that's all very interesting research. So you can see here some of the examples of our kind of intuitive variable naming. A variable like R1 work is whether the respondent is working at wave 1. We've also created spouse versions of these variables because spouses are generally interviewed to, or the spouse is asked about to the respondent. And the variables have been built to account for a survey skip pattern. So here's kind of just a really simple example. This is on the left, you can see MHAS, which is the Mexican study, and on the right is LC, which is the Brazilian study. And you can see they asked about smoking kind of in a different order and with different answer choices. So in designing a harmonized variable, what we try to do is say we want to create a variable, which is whether the respondent has ever smoked. We want to code it the same way across studies. And so in that, we kind of like account for the difference in question choices and the difference in the survey skip pattern in ELSI to really be able to code this, because really we think you are able to create a very comparable measure here. So we kind of do that work for you. This is a very simple example. This is like a much more complicated example. This is the Japanese study and how they asked about savings accounts in the household. And so we kind of go through all these different survey skip patterns and create the savings. Savings is like one component out of, I think, 12 in JSTAR for wealth. And maybe, especially since you're maybe focusing on, psychological outcomes, maybe you're not interested in all the different components on wealth and building these yourselves. I think what this gives you is kind of like a validated, consistent way designed by economists to using like a total family wealth variable if you want to, control for wealth in your regressions, or think about, is this process different for people at different wealth levels? Is something protective happening with wealth, perhaps? And so these are really important. We also provide documentation for each of our code books. You can see here, this is for the Charles, which is the Chinese study. This is our documentation of the harmonized Charles core data set, where we kind of introduce the harmonization project. We talk about Charles. We discuss the weights that are provided, any imputations that are done. And then we divide all the variables based into different sections. You can see here, we summarize the different sets of variables. I've highlighted the single item self-rating of life satisfaction variable here in Charles. You can see we've created it for waves 1 through 4. We've also created the spouse version of that variable. And you can see that we also code special missing values. So for instance, at wave 1, this question wasn't asked to proxy respondents. So if someone was answering on behalf of someone else, it wasn't asked at wave 1, but starting at wave 2, proxy respondents, but they still were. They were asked at every wave. But it also codes don't knows and refused. We talk about, we have text to kind of, in plain language, try to explain how we created it. We mentioned here that we both create, this life satisfaction as a category of these answer choices, but we also make a z-scored life satisfaction, which could be helpful for comparing a life satisfaction variable, which maybe, one study asked in a score of 1 to 5 and another asked at 1 to 7, for instance. And then we highlight any cross-wave differences in this study, and then differences between this study and the HRS, which we usually use as our kind of basis for comparison. And then we list all the variables from the originating data set that were used in the creation of this variable. And this is helpful, especially if you just want to like go back and look at, maybe you want to go back to the original study and you think, I want to bring in my own variables. I want to do something a little bit different. So you can go back to these variables and find them quite easily in the original data set too. So currently, these are the harmonized data files that we've built. We're in the process of updating, I think 3 of these and building 2 additional ones at the moment. But these cover the United States, Mexico, England, Europe plus Israel, Costa Rica, South Korea, Japan, Ireland, China, India, Malaysia. We're also currently in the process of building data sets for Brazil, Chile, and Northern Ireland. So those will be released somewhere between later this year and over the next couple of years, as well as updates as new waves of each of these data sets are being developed. I've also highlighted 3 of them here, which are the harmonized HRS, the harmonized ELSA, and the harmonized LASI. Gateway has started to develop what we call a data enclave, which is basically it gives you kind of a remote desktop with analytical software like SAS, SPSS, Stata, and R, where you could, and the data is already stored on these computers too, so you can kind of do your analysis there. Because in general, the Gateway doesn't distribute data sets itself, but the studies distribute these data sets for you. But it means that, if you're using 3 of these studies, you have to go to these 3 studies, also register with them and download the data. The Gateway has lots of links and details on how to get access to the data. If you just go to the Get Data page under Harmonized Data, But also, I think the enclave, as it continues to expand and more studies are included in it, we really hope that it kind of maybe gives like a single sign-on version of getting access to these data for your analyses. To find what's in the harmonized data sets, you can look through the documentation. We've also built a couple tools as part of the gateway. So the gateway has just a variable search. For instance, here I've searched for the word happy in MHAS, the Mexican study. And so you can see that it was included as part of the CESD scale in the psychological module of MHAS at all waves of MHAS. And we've also built a variable concordance where you can kind of select topic and subtopic. I pulled up here a subtopic called stress and psychosocial content, and then satisfaction items. So you can see that we've created harmonized variables for domain satisfaction, satisfaction with family and friends, and satisfaction with life. And you can see kind of which of these data sets already have the variables you're interested in. So satisfaction with home, there's already a variable been created as part of the harmonized HRS, harmonized ELSA, harmonized LASI. Satisfaction with city and town has been created in the harmonized HRS and harmonized ELSA. And I'll just highlight, instead of you going through all these pages, I'll kind of highlight as a broad, by these kind of broad measures or topics, whether harmonized variables have already been built or are available by study. So you can see that the HRS has all of these different stress topics, as does ELSA, and mostly tilde. And then you can also see, for instance, like LASI includes questions on neighborhood disorder, lifetime stressful events, and discrimination. Charles, the Chinese study, has lifetime stressful events and parental warmth, but they don't have some of these other ones. MHAS, the Mexican study, only has the questions about social support. So you can see kind of, and some of these, I should say, if it's not checked here, it doesn't mean it wasn't asked. It means that we're in the process of building and updating these. But I just wanted to give you a sense of what's currently already built if you're wanting to really get started on your research. Similarly, with the emotional well-being variables, you can see here that we have these different topics ranging from life satisfaction to experienced well-being. So the HRS has had variables already built for all of these, as has ELSA, with the exception of Cantrell's ladder and the Midas scale. And then some additional studies have them. Life satisfaction, of course, is the one that is covered by the most of these. And I'll just show you just some quick tables that we've made that kind of give you a sense of like really kind of the power of what you can do with these. So this is the CAPS scale, which kind of divides into control, autonomy, pleasure, and self-realization scores. And we've looked at this both in the ELSA data in England and the JSTAR data in Japan, and we've separated these out by education levels. And so one of the things you can see is that there are some, real education gradients happening across all of these. Interestingly, between control, autonomy, pleasure, and self-realization, the kind of level of scores between each other across England and Japan look quite similar, but Japan seems to have a kind of a greater educational gradient to these, particularly with tertiary education, people having higher scores for these things than for less than upper secondary school. These kind of like education levels, like international education levels, is something that's also built into the harmonized data sets. And here's a look at 6 different countries, and this is the job stress scores. And we've kind of divided it here by low wages, middle wages, and high wage jobs, and those are inside of that country, basically. Wages is another harmonized variable that we've built. And so one of the things you can see is that, in some countries like the Netherlands, interestingly, there just seems to be like no difference in stress scores across people of different wages, but particularly like in Denmark, it seems very pronounced. Also in the United States and in Spain, high wages jobs are associated with less overall job stress. So I think there's like a lot. This is just 2 kind of interesting things that I pulled out as you think about what you can, the kind of power of combining these multidimensional aspects of aging and people's life experiences in late middle ages and older ages. So to use the gateway, all you need to do is register. As I said, it's kind of a free public resource. So you just register and confirm your email. We do ask that if you publish based on using harmonized data or information from the gateway, that you would include this citation, which includes our funding information. So you can learn more. You can visit us at g2aging.org. We also have a help desk. So if you have any questions about whether a certain study includes this measure or doesn't include a measure, or you're having trouble getting access to a data set or just understanding the gateway, please email us at help@g2aging.org. There's like a whole team of people who answer these emails, and we try to get back to you within around 24 hours during the work days. We also have kind of an index of webinars, that past webinars and presentations that include some that are focused on stress and well-being, as well as some blogs that we kind of regularly publish. They can be about certain topics in studies. They could also be an update of someone's recent paper, or maybe an introduction to a new study. So it kind of wraps up what I wanted to say about getting started. And I'm happy to, I think we do have some questions. So I'm just going to start to answer those. And if you have more, you add them to the question and answer, and I'll happily read them also. So the first question from Dipendra is, I could not find age, sex, ethnicity, or other sociodemographics related in harmonized data set. Why are they not included? So they absolutely are included. So you can correct me if wrong. My guess is that you might be trying to look at HRS data. And there's actually two kind of sets of HRS harmonized data. So one is the RAND HRS data set, and that's where you're going to find gender, ethnicity, education, other socioeconomic demographic variables. And then the harmonized HRS is really a supplement to that. And that's where those emotional well-being and stress variables are. We didn't want to duplicate the work because the RAND HRS has been in existence, for 20 years or something. So we have just added to the variables that they didn't do, but you would use those two in conjunction with each other. Outside of the HRS, though, all of them would be in the one data set called the harmonized data set. The next person asked, anonymous asked, when are you planning to incorporate Charles 2020 data into the harmonized Charles? So we just started to look at that. As you know, I assume they recently released it. But actually, because that survey was done during COVID, it's quite a different survey. So at first we thought we could probably update the data set quite quickly, but they've changed the instrument so much to make it shorter because it was just done differently during COVID. That I think our best guess, we actually talked about this last week as a team, I do think it would be at least towards the end of this year, if not next year, to have that data incorporated for Charles. So it's something we're just starting to work on now. And then a question from April is, I may have missed it, and I apologize if you are already answered. However, I previously requested tilde data and received the following response. Yeah, so the response that this must be quite recent. So the response that you request that they gave you was that according to some legal issues, that they can't supply it to people who are outside of the EU. And so that's absolutely true. That's like a very recent thing with tilde data that we are also working on. The tilde team is also slightly frustrated by these new rules that they feel are restricting people when it was really intended to be designed to be comparable to this global network of studies. So it should be able to be used by anyone, not just people in the EU. So we're in probably pretty regularly talks with the tilde team about trying to see if they can get approval to put their tilde data on the Gateway Enclave as a way that then we're not distributing the data, but people have access to it. So if you sign up on the Gateway and you sign up for announcements, assuming that process continues and goes forward, that's the best way to make that happen. I think really the only other way is to visit Ireland, to be honest, currently. But that's a new situation, and I think that's the only country that has that situation, and it's a result of some new rules that were passed in Ireland, particularly to Ireland. This doesn't apply to share, or ELSA data, or Nicola, the Northern Ireland data, or Haggis, the Scottish data. Ireland has a specific set of rules that are quite new and very restrictive, and so they're navigating that situation. So I don't have tons of great advice there, other than it's truly being worked on both by people on the Tilda team and people as part of the international network. And let's see, I think there's some more questions here in the chat. Do you know if there are any plans to harmonize the CLSA with these data sets? That's the Canadian Longitudinal Study on Aging. Yes, we are also talking to their team. I think we'd like to. I think it's a really interesting study. A lot of participants. Currently, their model is that you have to pay to access the data. And so far, our team has always focused on data set that's like publicly and freely available. So I think we're still in talks to them, and I certainly hope that we're able to incorporate them in the future. And then from Alyssa, where do people go with questions? So I think you could go to help@g2aging.org. You can email us. That's also, if you go to our website, that's like one of the things that's on there you'll be able to find. We also have different things coming up. And if you go on the Gateway, if you go to announcements, you can see different initiatives that we've had. For instance, we've hosted hackathons in the past. We have some webinars that are coming up. One's focused on a part of the Gateway that I didn't mention, but it's our Policy Explorer. And so I think we've talked a little bit during this webinar so far about people's cultural context. Policy and institutional context is also important. So that's something that we have been working on bringing into the Gateway and making available to people. And so that's one of the new webinars that we'll be having. And we are planning, hopefully, I think in 2025 to co-sponsor, the Stress Network will co-sponsor a hackathon with the Gateway. And so we would, anyone who's part of this, we'd love you all to apply to be part of it. The last hackathon we had was like really fun. It's kind of an intensive 3 or 4 days where people worked in teams to try to answer some data questions and get results. And those groups that people formed at the hackathon, continued after the hackathon. Alyssa, do you want to say more?
Well, I'm just so excited about what happened at the hackathon and how much progress and discovery was made in just a few days. What is your suggestion to people who, besides coming to a future hackathon, what they can create at their own universities? What would a team look like? We had 3 amazing examples today, and I know it took a lot of time and work. And ideally, we wouldn't do this, alone or with just an advisor or small team. So what's the formula for success in using this data?
Yeah, so it does, in one respect, I think a lot of the work that the Gateway and the harmonized variables has done has cut out a lot of work for you. But I'm sure all 3 presenters today can really speak to that it's still a lot of work. And, it's a lot of like actual, like kind of hard analytic work. And there's also just a lot of like conceptual work. I think about what is the culture? How are people responding to these questions? What are we measuring? What the question that was brought up earlier, we're measuring something that's already been mitigated by other things. And how does that influence it? So, I think for me, finding good co-authors, finding people who have expertise that are different than yours, especially, I think for me, I've learned, I have an economics background, but I've learned so much from working with psychologists and geneticists, econometricians, different health researchers, policy people. I think forming those networks is so important for really getting research off the ground. And also, maybe I'm personally very socially motivated. So a large group of people also helps to motivate me. So that's some general advice that I have.
Yeah, that's a fantastic answer. And for the awardees today, they actually got a grant for doing the analyses. And in the past, we've had people be connected so that they can serve as resources for each other. And that was really helpful. So, developing a group of other people working on these same data sets can lead to more collaboration papers and also just, resources in terms of getting statistical or other quirky questions answered about the data sets.
And I know we're at time. There's one more question, which I'll answer quickly. Does this include cause of mortality? So that's a great question. That depends on the study. So generally, especially in the end of life data sets, if the study has collected cause of mortality and releases it, then that is included in those harmonized data sets. But the amount to which studies kind of give specific causes as opposed to maybe something more broad is dependent on the study itself.
And with that, we'll hope for lots of studies on healthy longevity and delayed mortality. Thank you everyone for your time, and we'll be so interested to hear what you find. Keep in touch with us, the Gateway and the Stress Network, and we're here to support you. So thanks everyone. Thank you,